Good afternoon, members, officers and any members of the public in the public gallery or viewing from the live stream. Welcome to this meeting of the Scrutiny and Overview Committee. My name is Councillor Graham Cone and I am chairing this meeting. My vice chair is sitting to my right. I will introduce other attendees when I invite them to speak. Committee members, may I remind you that you should have before you the main agenda. Those in the chamber are reminded that the meeting is being live streamed. The normal procedure at Scrutiny and Overview Committee meetings is to review and make recommendations to the Cabinet by affirmation. Only those members of the committee present in the chamber will be able to move and second motions or affirm. However, members present virtually may speak in the debate. May I ask those who are joining us remotely to ensure that their camera and their microphone remain off unless they are addressing the committee. For those of us present in the room, please ensure your microphone is close to you and you speak clearly when addressing the room. Finally, a report of this meeting will be presented to Cabinet at its meeting on the 3rd of February 26. So we'll move on to the main agenda. Do we have any apologies for absence?
We do, Chair. We have 4 apologies from Councillor Bear Park, Councillor Fain, Councillor Stobart and Councillor Richard Williams.
Thank you for that. So declarations of interest. Does any member have anything that they would like to declare at all? Okay, so we'll move on. If anything becomes evident during the meeting, just raise it at that time. Minutes of the previous meeting, so pages 5 to 14. Are we happy that they're an accurate record of the meeting held the 6th of November? Does anybody have any comments that they want to mention on that? Okay, we will move on to public questions. I don't think we have any public questions, do we? So that brings us to agenda item 6, which is pages 15 to 24. I think we're going to have Claire to speak on this first. Hiya, Claire. Yeah, we can see you in the room. Can you hear us clearly?
I can hear you absolutely brilliantly, yes. And can you hear me okay?
We can indeed, we can indeed. Thank you for that. So we were going to invite you initially to go over the report that you've submitted and do sort of a little presentation, and then we will ask questions following that, if that's okay.
Fabulous. Yes, that's good.
Lovely.
Shall I make a start?
Please do.
Super. So look, I should just say hello. So my name is Claire Stoneham. I am the Chief Strategy and Transformation Officer for Cambridge University Hospitals. My Chief Executive, Ronan Sinker, is also due to join us. I'm afraid he's had some kind of train disaster this evening, so he is desperately trying to make it home, and he will join us as soon as he can. Can I just say, so first of all, look, thank you very much for the invitation, and it's really good to be here with you this evening. Looking forward, I hope, to a really good discussion on the paper and the issues around it. I mean, I suppose I would just say to start off, I think we think this is an extremely important area for local people, the population, and part of what we're doing, I think, in this sort of early stage of strategy formation is trying to get out and really have a range of different conversations to discuss the ideas and the approach and try and make sure that we're moving forward in the best way. So if I just sort of summarise what is in the paper, and I obviously won't go through all of it in great detail. What I think you've got as a committee today is a summary of about a year's worth of work on a new model for urgent and emergency care. And what I think this comprises is both some initial thoughts about what a new acute hospital for Addenbrooke's would need to look like, but very much situated within a different model of care, a different model of healthcare for the local population. And really what we're drawing on here, I think, are ideas that you can also find within the government's 10-year health plan, published earlier in the summer, and also the work that we've been doing as a hospital trust with a range of partners, including GPs, yourselves in the district council, the county council, community services, over a period of at least 6 years working within that health system. And I think, again, what we're trying to do with this piece of work is really think about how we as a trust, as part of the healthcare system, need to be responding to the growth of the population in Cambridge and the surrounding area. We've seen, as you all well know, quite significant growth over the last period of time, and the government's plans are that the population should continue to grow. Well, that poses some real questions and challenges for us as a provider of healthcare services. We're also very sort of motivated by trying to ensure we have the smallest possible hospital footprint. We know that if resources are spent in providing hospital care, they're not spent in the community and with care closer to people's homes, and that very often isn't the right way of deploying those resources most effectively. And we're trying to be really thoughtful about how the kind of whole healthcare system can be sustainable whilst also meeting the needs of our growing and changing population. So if I just very quickly on the kind of case for change, I think there are sort of 3 layers to this. So nationally, we can see a model of urgent and emergency care for the country that is increasingly not fit for purpose. And again, you can see that through a range of different material coming out from the government and elsewhere. Too many people ending up in hospital that isn't the best place often to meet their needs. As I've said, though, we've got particular challenges within Cambridge with a growing and ageing population. And actually, I think we're one of the fastest growing places in the country. So for us at Addenbrooke's, that means being really thoughtful about how we respond to that. And then we are also, again, as you know, situated on the Cambridge Biomedical Campus, and we think that brings real opportunities in terms of our work with university, with industry partners, on research and innovation. And we think we've got a responsibility to try and capitalise on some of those areas. So the paper you've got, we call it our acute care strategy, tries to describe some of the components of the new model of care that we think we need to be moving towards. And I'm happy to sort of unpack that in response to questions, but really at its heart, I think what we're saying is that we would want people only to be coming to hospital when that was absolutely needed, and that was the sort of only place that could meet their healthcare needs, and increasingly also for care to be planned wherever possible. So even if a healthcare need is urgent, somebody needs to be seen on the day, can we increasingly move to a planned way of doing that? Perhaps you do need to wait, but could you wait at home rather than an A&E waiting room? So really trying to think about how we respond differently to those healthcare needs when they arise. I'm nearly done, Chair. So just a couple more points before I finish. In terms of, well, it's fine. I don't want it just to be me talking, so I'm keen to get to your questions. Just in terms of next steps, and this is in 2 parts for us. So the first, as I've signalled right at the outset, is we are trying to work towards a business case for a new acute hospital for the Addenbrooke site. Again, you will all know that the healthcare estate currently is ageing, not necessarily fit for purpose increasingly, and it will only obviously deteriorate over time. So it's important for us that we start to work towards a business case for a replacement building in due course. Now, I totally recognise that that takes a long period of time. Part of my job also is to work on the cancer and children's hospitals, and I've spent 5 years developing the cases for those. So this is not something that happens overnight. But actually, if we don't start the work now and we don't start thinking about what that hospital of the future will look like, we are anxious that we won't in due course be able to meet the needs of that growing population. And actually, as the government, Cambridge Growth Company, is thinking about how to support the development of Cambridge, it's really important for us that the need for healthcare infrastructure sits alongside consideration of transport, of utilities, of water, of housing. It is, from our perspective, another really key component of what will enable that good, successful growth of Cambridge. The other thing we're doing on, I hope, a sort of more shorter timescale is to start to put in place components of that new model of care more immediately and to build those up over time. So ultimately, we think we do need a new hospital building, but there's lots of things that we can do in advance of that to start to work differently with GPs, with our partners in the community and councils. So some of you may have seen in the news just at the end of last week, we've recently launched our new, what we call a sort of digital front door, a new way of booking in to the emergency department, along with some refurbishments of our urgent care centre. Those are things, again, that we think we can further develop over time. We've been working very closely with our partners in the Cambridge and South Cambridgeshire Care Partnership to start to trial and model different ways of supporting people's healthcare needs. So, for example, our frailty teams, our geriatricians, spending more time working directly alongside care homes and actually having a really significant impact on the number of those residents then that find they need to go to hospital. So by getting in there up front, by working in a different way with teams out in the community, we're finding we can reduce the need for people to have to come to hospital. And I think particularly for that cohort, that is a really, really good thing. And then the other thing we're doing is thinking about our sort of outpatient services and how people access different parts of specialist care. Again, that historically has been a very hospital-based model, but increasingly in areas like neurology, for example, we're trialling different ways of our specialists working alongside GPs, so that actually people can access that advice more quickly. Perhaps they don't need to join a waiting list and wait for an appointment to get the input that they really need from one of our specialist doctors. So there's lots of different models that we're working on, that we're developing and that we're looking to implement well ahead of any new hospital building being developed. I will stop there, Chair. Hopefully that was kind of helpful as an introduction. So really good to have some questions and get into the discussion.
Thank you for that, Claire. So we'll move on to questions. Who would like to go first? Councillor Earl.
Yes, Claire, could I ask, this depends very much on care in the community working and working a darn sight better than it does at the moment, but let's be honest. Has a costing been done for this? Because the community services are going to have to expand considerably and also be remodelled because they are not working properly at the moment for people. Has that costing been done? That's number one question. And two, has this model that you're proposing, this new healthcare model, been tested anywhere else and validated?
Thank you for that, Councillor Earl. Claire.
Super questions. Thank you very much. So in terms of the model, So what we did to develop this care model is to really look at where right across the world at all sorts of different healthcare systems, and to look at different components that people have implemented successfully in different places, and to really try and learn from and understand what has worked well elsewhere. So I am confident that all of the kind of component parts within the model are based on evidence, have been implemented in other places. What we also tried to do with this model, though, is to be genuinely quite ambitious, and to we didn't want to describe something that felt actually quite close to where we are now, that didn't have the right level of ambition within it. And the motivation for that is not kind of getting carried away with ambition for the sake of it, but it is quite, I think, a sort of grounded assessment that if we carry on as we are, we will end up with more resources in the hospital and more people coming to the hospital than we think is the right outcome. So what I think we don't have is all components of this model implemented, verified, and with a kind of, yes, if you look here, but we can see the different parts working together. In terms of the resource, look, you're absolutely right in terms of what this requires. And I think there's a few things I would say to that. So one is, there is a reason that we are putting a lot of attention and energy into the Cambridge and South Care partnership, because really working well with community teams in a different way, and you're totally right, this is not working as it needs to at the minute, is absolutely fundamental. There are, again, places in the country and other parts of England that have got this working a lot better than we do locally. So we can see evidence and examples from lots of different parts of the country that I think give us confidence that it is possible to do this in a different way. Just the other thing I would say on resources is, again, we did lots of kind of workshops as part of developing this, and lots of talking to different professionals. And one of the things that came out from that is that actually there is quite a lot of overlap and duplication, inefficiency, people perhaps having to go to multiple teams to get what they need. Now, what I'm not saying is that we can absolutely do all of this within current resources. I think we haven't done that full costing as you've described. There is more for us to do to develop this. I am confident actually that we can make much better use of our existing resources than we currently do. And I think that's a really important place for us to start, to say, actually, how could we, as a health system and with partners, do better than we do now? And that should hopefully unlock further opportunity.
Councillor Earle, I'll come back to you.
Yes, I think it would be very useful to have, if you're going to present this sort of paper elsewhere, to have some examples of where some of the strategies that you mentioned work, and how you envisage them coming together, because that is actually missing from this at the moment. The other thing I would say is the IT systems at the moment that simply do not talk to each other are a major source of poor communication and actually disjointed care, and that worries me considerably. You have touched on it in here, but you haven't actually addressed it. Claire.
So yeah, thank you. So if it would be helpful, I'm really happy to share with the committee after this some of the case studies and evidence. The full report is 175 pages, and I was given very strong guidance that you would like something more succinct for this committee meeting. But I'd be really happy to share some of the case studies and evidence that sit behind that report, if that would be helpful. And again, in terms of the IT and data, look, I think you're absolutely right. We are making some good progress on this, I think, but there is absolutely more to do to join it up and to get it working seamlessly. And I think, again, part of this for me is it isn't just about the health systems talking to each other. It's increasingly how we're going to put the patient or person in control of some of this. That's not necessarily going to be right for everybody, but one of the things that you can do with my chart, which is the kind of patient interface for the ADNBRIC system, you can increasingly interact with the hospital in a very direct way. One of the things that we're shortly going to be rolling out is self-booking of outpatient appointments. So again, increasingly, I think for us thinking about how we can give control to people and citizens so that how they interact with the healthcare system is something that they can control rather than it just being, you know, the doctors talking to each other, for example.
Thank you for that. Councillor Earl, did you want to come back on that at all?
Just to say, we are well used to extremely weighty reports here. The last one I read was 700 pages, so we have no fear of reading 175.
Sounds like Councillor Earl will be very happy to receive those additional papers, Claire. So we'll move on. Councillor Bradnam.
So, Chair, I have a lot of questions, but I'm going to start with 3, if I may.
Yeah, let's just take a couple at a time so they're manageable.
These are linked, so
Lovely.
I'd like to. So the first one is a precursor question, which is the reason that you have come to Scrutiny and Overview here at South Cambs District Council. We have a habit at our pre-scrutiny meetings of making suggestions, asking questions, the purpose being to improve the paper that is then going somewhere else. And I'm hoping that you're nodding, I'm glad to see that, and I'm hoping that that is because you're prepared to take on some of the suggestions that we're making this evening and maybe alter some of your text according to what we're asking. So it was just a clarification that that's what we are happy to do at Scrutiny. It's to improve the document that's going to go on somewhere else. So my first major question is, it's about where the money's going to go. So you're talking about the operations going from the hospital into the community and into neighbourhood solutions, but will the money follow that work? So that's paragraphs 2.1, pages 15 and 16, where you talk about this shift from hospital to community and the creation of neighbourhood hubs. So will the money follow? And the second half of that is you'll be asking Cambridge Growth Company for £10 million towards a new business plan and for the new hospital. But will the money for that, for those 4 new hubs, come from that 10 million? I suspect the answer is no. So where is the money for these new hubs going to come from? Because they're not currently in our draft local plan, which we're currently consulting on in South Cambridgeshire. So that's really to do with where's the money and when are they coming from. And
shall we take those,
okay,
Councillor Bradnam? I will keep coming back to you. So, Claire.
Yeah, great, thank you. And yes, the reason I'm here is absolutely to have your comments and suggestions on how we develop this. I think what we're doing is trying to work out what is the right strategy and plan for healthcare for the next period of time, and we absolutely can't do that on our own. And some of this actually is building the case to the government and others around some of those questions you've asked on funding. So if I try and address those specifically. So yes, we are absolutely looking to shift activity in due course from hospital into community settings. And yes, absolutely, the money will then need to flow in a different way. I mean, yes, that is the clear intent and purpose behind this. If we keep on doing what we're doing at the minute with the number of people coming to the hospital and receiving their care in that way, then as a healthcare system, I very strongly believe that we're going to run out of money. It's not an affordable way to continue to provide healthcare in the future. In terms of the new hubs, you're completely right. They will not be fully funded from that £10 million. We need to do some more work on exactly what those need to look like, what services will be in there. Again, you're seeing this at quite an early stage of its development. I don't have all of the answers by any stretch of the imagination. What I think we're saying here is, in order to be able to shift services from hospital in the community, we are going to need a number of bases where those services could move. And I think one of the the kind of things we have to do next is work out where could those be, what would they need to look like, what are the opportunities for funding them. So the government announced around the time of the budget that there would be some money brought forward for neighbourhood health centres. So I think, again, one of the jobs we have with our partners is to say, is there an opportunity that we could bring forward more quickly to start to create one of those? What would that look like? But this is going to be a lot of hard work, detailed development of ideas with our partners, and then lobbying of the government and others to try and bring some of these things forward.
Thank you for that. Councillor Bradnam.
Thank you. Good. Lobbying government, because I'm just wondering where the money is going to come from. So I'm just hoping that you're looking at this holistically. I think you are, but where the money is going to come from for this holistic approach, I'm not sure, because for example, at the moment, the County Council has instigated a regime of essentials only, because without this approach, the County Council was facing a £12.3 million deficit in its budget. So clearly the County Council hasn't got money to spend on this. And I know you said you'll be lobbying government, but I just wanted to be reassured that you'll be lobbying government, not just for the new hospital, which obviously is important, and I understand the need for new buildings, but also for all this other infrastructure which is going to enable this community element, or the community network, if you like, of care to be provided. So it's really, where do you think the money is going to come from? And, are you aware that some bodies are not in a position to maybe fund?
Thank you for that, Councillor Bradnam. Claire.
Yeah, absolutely. So, look, I'm really clear. We're really clear. I hope I'm conveying this, that the shift into the community and the neighbourhood health centres are not an optional extra. They are absolutely critical for enabling the different model of care that the acute care strategy describes. And I think that model of care is essential for us to end up with an affordable and right-sized hospital down the line. So you've got figure one in your paper, compares the difference between and this is an estimate, clearly modelling. But if we implement this new model, we think, even with an expanded population, as a hospital, we need approximately 1,000 beds. That's the blue bit with the sort of red dotted line around it. The middle box describes what we think would be needed if we didn't make any of these changes to the model of care and we didn't implement the neighbourhood centres and care in the community in the way that I'm describing. And you can see that's a hospital that's twice the size. So that obviously has an incredibly significant impact on the cost of that hospital building, both the immediate capital cost for building a hospital twice as big and then for running it. So part of the business case from my perspective for this new hospital, it's totally dependent on those new centres. So we are wrapping in to our business case, if you like, the provision of that care in the neighbourhoods, because the new hospital only works if that is implemented. Sorry, have I explained that? Hopefully I've explained that
yes.
okay.
You've said that you're looking for funding for both, which is important.
Yeah, absolutely. And recognising though that NHS capital is really tight, right? And we've come out in this report with a very large number. 2.3 billion pounds is a lot of money. So I don't think there's an easy route to getting that funded, but it's definitely not a pick and mix, I suppose, is what I'm saying to finish.
Thank you for that. Councillor Bradnam.
Thank you. Just a couple more things. Firstly, I think it's a very good idea, the idea of geriatricians working more closely with care homes. I think that's excellent, and it can save GP surgeries, a whole lot of extra work. And in fact, my own mother was beneficiary of such a system at her own GP surgery, where a dedicated person went to the care home and worked very well. The other thing was, and this is just a request, is paragraph 3.5, you talk about your new Cambridgeshire and South Care Partnership. And I'm glad you naturally called it the South Care Partnership, because I don't like the name South Place. It sounds like South Fork or a developer or a housing arrangement. It doesn't have care in it anywhere. So my request would be, please keep care in the name somewhere. Otherwise, people won't know who you are. So that's just my little request for you.
Thank you, Councillor Bradnam. Claire, did you want to comment on that at all, or is that noted? Yeah.
Well, it's great. Look, it's a very clear request. I think sometimes we lapse into shorthand, of which the South Place is. I've been trying to give it its proper name in this session, and I think your encouragement to do that so that people know what it is and what it's for is really helpful. So thank you. It's just a bit of a mouthful, but anyway, we'll
certainly,
yeah.
If you can keep care somewhere in there. South Care Partnership might be better, or something like that. But
thank you for that, Councillor Bradnam. If you have any further questions, we'll come back to you. Councillor James Hobro.
Great, thank you. So my questions really follow on, I think, fairly naturally from the last few. So it's clear from what you've said that this more localised model of care delivery is absolutely essential to the issue of avoiding having to scale up a centralised system beyond its limits. So I think that it seems that, therefore, that the design of this localised network is going to be key in terms of the success of a new model like this. So I just wanted to probe a little bit more on what has or hasn't been decided at this stage. So, I mean, my first question really was, so the document talks about neighbourhood health centres, and so immediately I thought of GP surgeries, or perhaps larger clinics, or perhaps a mixture of reimagining GP surgeries and some larger clinics, and maybe even involving some of the sort of pop-up care, so in community centres where things, so today we have the blood donor service, for example, operating temporarily in community centres. So I wondered if you could explain the thinking so far and what it will look like, how different it is physically from what we have on the ground today, and if this does involve reimagining GP surgeries, will that be difficult? So we have the buy-in from the practices to reimagine them, I see lots of opportunities here for different systems, but it's not quite clear what's in mind and what the risks are. So sorry, if I could stop there, and then I might come in with a couple more questions afterwards. Thank you.
Thank you. Claire.
Yeah, really good questions. Thank you. So what has been decided you know, in terms of kind of firm decisions, I mean, I think we're not at that stage. What I would say, particularly on your questions around, so this is what I'm describing is not a replacement for primary care for GPs. We've played with the language a little bit for how we describe it, and at some point we were sort of talking about it as mezzanine care. So it wasn't sort of full in a hospital, it wasn't primary care, but it's what could sit in the middle. And I guess the key component of that is what we're trying to get at here is things that would previously have been done in a hospital, but being done in a community setting. So again, that's not a replacement for core general practice. That's an incredibly important role and set of services they provide, but we are talking about something that has more specialist input than, and by specialists, sorry, I mean GPs are absolute specialists, I mean consultant level input. I think the closest probably we've got to something that looks a bit like a neighbourhood health centre at the minute is at the Princess of Wales Hospital in Ely, which is obviously in East Cambs, where we've got a minor injury unit. There are some outpatient services. There is a community diagnostic centre, so that does MRI, CT scans, phlebotomy, various other things. And actually, Addenbrooke's runs quite a busy day surgery unit up there as well. Now, that isn't running as I think we would envisage a new neighbourhood health centre fully running at the minute, but those are the sorts of things that when I'm thinking about what would this need to look like, I'm thinking about. So how can we develop the urgent care provision so that people don't have to come to A&E for a range of illnesses and injuries? How can we develop, say, what the care that is currently provided in an outpatient setting, but could be done in a different way, and particularly expanding the diagnostic provision as well. So those I think are some of the key components that we're thinking about.
Thank you for that. Councillor Hobro.
Oh, thank you. So I suppose that sort of brings me on to my next question, which is about to what extent has this level of sort of devolution of care within a community setting like Cambridgeshire been tried and tested in another county? So I know Councillor Earle asked a general question about how much of this is tried and tested, but I mean specifically in terms of the devolving of care to smaller centres. Is this a model that we've actually seen operate elsewhere in the UK under the NHS, or is this something really very new that where we will be the pioneers?
Claire.
Yeah, so I mean, I think that the ideas behind some of this, I think, have been around for really quite a long time. And I've worked in health policy for, I don't know, 20 years or something. And people have been talking about this for all of that time. And I would say there have been lots of experiments in it, and some parts of the country have made really quite significant progress. So I might point to areas like Dorset, for example, and sort of around the Torbay region. They've been running an integrated model of health and care for years and years and years. So there are absolutely examples of how this is up and running and working very effectively. I think the other bit, though, is some of the components that perhaps were needed to make this work really effectively perhaps haven't quite been. So you might ask the question, well, if that's the case, why hasn't it spread everywhere? You know, have we made as much progress on this as we could and should have done? And I think there are some other particular enablers now that should allow us to move faster with it. So things like the technology that I've talked about a few times, you know, actually being able to ask for urgent care on your phone, book into a same-day appointment in the hospital, have that connect through to your records and your GP surgery. I mean, that wasn't available 20 years ago through the NHS app and with all the systems. it is absolutely on the cusp of what is achievable now. I do also think actually government policy in this space is very helpful. So they're being quite clear about the expectations of us and partners around developing a neighbourhood health service, and really thinking about things like funding flows, who gets paid for what in what setting, which again I think should hopefully make it easier for us to implement some of these things in practice. So yes, absolutely, people have got it right in England already, and I think the kind of context and environment for us is such that it should allow us to move further with it now. Hello, Roland. Good to see you.
Thank you.
Could I ask one more related question, and then I'll
Please
save
do.
my others till later, if that's okay.
Please do.
So it's about, it's really slightly repeating something I said earlier. So the current GP surgeries, would this new model require significant change of the way that they operate, or not? And if so, is that going to be difficult? I mean, will they want to change to fit in with the new model?
Claire.
Yeah, so thank you. So again, I don't think the model of care we're describing here gets to how GPs deliver core primary care to their local population, that they are absolutely experts at, and really developing how they do that. It does talk, I think, to the interface between GPs and the hospital, and how we can work better as professionals together, so that perhaps that sort of old model of you go to your GP, you get referred to hospital, you sit on a waiting list for a period of time. We think there's a way of making that much more dynamic so that people can actually access specialist input much earlier. So that does require people to work differently. It requires the hospital to work very differently, and it will require GPs to work differently as well, I think, in some of to make some of those connections and to make it function effectively. We are absolutely trying to work very closely with GPs. We've got lots of them represented or working with us on the Cambridge South Care Partnership. I was actually with the GP Collaborative last Tuesday, having this exact conversation with them about the acute strategy and the things that the hospital is really focusing on for the next phase. So this is a really live conversation with primary care as well. I think what I take real kind of comfort from, excitement from, is actually there are lots of conversations at the minute. We want to do something in respiratory care. How can we work together differently for people who are asthmatic? How can we develop the pathway in neurology so it's not just for a small group of GP practices, but it's rolled out across the area as a whole? And it does feel like there's real energy behind some of those conversations from my perspective.
Councillor Hobro.
Great, thank you. I think I'll stop with my questions for now and let others take over. But I'd love a chance later.
I might just come in on because it's on that point, and then I'll come on to the next speaker. So, like Councillor Hobro, I think some of how we sort of communicate this to residents is important when we have a fairly big transition. I think actually things that alluded to in the report, like my chart, virtual wards. If you looked at oncology, where you've got like the assessment unit and patients can interact sort of with that over the phone or virtually, I think those things work very well. And actually where you have patients that are really quite concerned about potentially being on a virtual ward, some of the benefits that they then get from that, they really like the structure of that, being able to be at home still and so forth. Most of those examples are in kind of like, outpatients, if you like, I suppose, or where you've prepped someone to go into a virtual ward from the hospital. I wonder if you wanted to comment on, do you think it will be a lot more difficult to do that in acute care? I know you've alluded to some of the things that would prevent people coming into hospitals, but I think residents and patients might worry a little bit more about an acute service being more arm's length or virtual, or how they engage with that. So really, I suppose what I'm trying to say is, I think probably a shift is a positive thing, but it's how do we communicate that to residents so that they understand the processes that they have to go through to get to the service that they require, and that they have confidence in that and feel comfortable. It's sort of building on Councillor Hobro's point, really. Claire.
Yeah, thank you. It's a really good question. And, you know, I mean, the system at the moment is quite complex, actually, sometimes, isn't it? And I think sometimes people struggle to kind of, well, what is the right service to me? Or I've tried this and I haven't been able to get in, and therefore, how do I respond to that? I mean, what I would say is, look, the hospital as a place to go for people who are acutely unwell absolutely remains the case under this model, and we're really clear around our responsibilities for looking after people when they are really poorly. And part of the reason we're doing this work is to make sure that we're protecting our capacity to do that as the population grows. I think what we also see, though, is people do end up coming to the emergency department at Addenbrooke's, either because they haven't been able to access a service elsewhere. Actually, quite often, sometimes talking to our clinicians, people end up coming in because they need access to a relatively simple diagnostic, but they're not able to get that in the community. So actually, we have examples of people ending up coming into A&E because they need a blood test, ending up being admitted to hospital, and particularly for that kind of frail older cohort I referred to before, that can, you know, lots of time in hospitals, sitting in a waiting room, you know, we know that you know, can be, one, can be a poor experience, and two, can make it much harder for them when they do get home afterwards. So I think there are things about the current system that we are genuinely looking at how we can improve through this model. I can see Roland's got his hand up, so I'll come over to him.
Yeah, I mean, I would just say on that point, I agree with you. I think the principles here are very good ones that the government have set out. You know, people want care and diagnostics and services more local to them. They want tech to make things easier, and they want things to prevent them having to attend acute services in the first place. And I think if we can communicate that, you know, in a way that people understand, and then, you know, they feel secure in the transition into those new services, I think that could be a good thing. Roland.
Thanks very much, Claire, and thank you so much, colleagues, for inviting us along today. And so sorry I was late. I got caught up in difficult travel.
No
Completely agree with it's a hugely important question, and thank you, Claire, for the answer. I think we have some examples, Claire, don't we, where we've reimagined or rethought what genuine patient and community involvement in a particular service can look like. And I think we've gone a long way in terms of our vision for children's services with our partners at Cambridge and Peterborough Foundation Trust and the university, and also in cancer. And I think, say, Rosie Maternity Voices has been quite powerful for us. And Claire, I think we've worked very well with our communities on the vision for acute services. And Claire, what's in the longer document, I think, are very specific examples, like our work in respiratory. So in COPD, what patients care about more is pulmonary rehabilitation in the community and rapid access to a hotline when they're in difficulty, and doing all we can to avoid them being dragged into the hospital on a cold night in November, December for non-invasive ventilation on a busy ward. So it's taking that and applying it to all of our acute services, but in quite a tailored and specific way. Thank you. I'll hand back.
Thank you for that. I will come on to Councillor Drew.
Thank you, Councillor Cone. There are, I suppose, some kind of controversies in terms of accepting data in relation to certain things, such as the number of hospital beds per 100,000 people, for instance. So therefore, I know it isn't as simple as maybe kind of publicly published data might be. But I just wonder whether you can talk to the fact that over the last few decades, there has been a movement in the UK, in the NHS, to reduce the number of hospital beds, no doubt for entirely appropriate and sensible reasons, no doubt modelled by NHS leaders, by doctors, by government, by others, and no doubt done with absolutely positive intentions. Yet residents and patients will often hear and read and see reports that suggest this may not have been the best thing to do. And at times they will see reports regarding, for instance, flu outbreaks and other such things that place great strain upon the NHS. So I think that patients, residents, whatever, seeing this, where you are talking about wishing to reduce the number of hospital beds from the current situation, will understandably feel concerned about the fact that they perhaps already believe there are insufficient hospital beds within the NHS locally, and you are talking about reducing the number. So what will be your very simple, very short way of convincing local people that the concerns that they have are not going to be made worse by this plan?
Claire, shall I come to you in the first instance, or Roland, did you want to
Roland
take that?
put his hand up, so he can
Fine,
go
yeah.
first.
Roland, go ahead.
Great. So three very brief answers then. So first of all, residents and our community are right to be concerned about this. In the Addenbrooke's emergency department, when I walked through it this morning, there were 3 patients in the corridor being well nursed and well looked after, waiting to go into beds in the hospital. So this is a real challenge that we need to acknowledge, and it's very difficult for those patients in that corridor, however well they're being looked after. I think the key answer here is, sorry, and this is going to sound awfully managerial, but it's to have the right sorts of beds. So to give 2 examples, having single rooms available for patients who have infection, so that you can put them in the right place and avoid them passing on that infection to other people, are absolutely vital. And for us at Addenbrooke's, we have a very small number of those sorts of beds, which is why we have to be very careful through the winter infection season. A similar example would be the taxpayer-funded elective orthopaedic centre, where we're just doing spinal work and joint replacements for our patients. There, it turns out, rather than needing enough beds for a length of stay of just under 5 days, we're now down, I think, Claire, at just over a day for each of the patients. So that's an example where we need fewer beds in the organisation. And then I suppose the last thing I'd say is, as is set out in this document, and we've given some of the examples of it already, we're going to have to work in a different way as we design a new model for our staff, how they work, and how we work alongside our patients and our communities using technology. That isn't to say that just tech is the answer, it's how people work together in a different way. I'll hand back.
Okay,
Can
great.
I just add one? Sorry, can I just add one thing to that? And sorry, I hope this isn't an overly pedantic point, but again, if I just refer to figure 1, actually, we're not talking about reduced number of beds in the new model. It describes an increased number of beds as compared to the baseline. And it also describes an increase in the number of intensive care beds, to Roland's point around the right types of beds for a hospital to have, and additional capacity in the emergency department. So what I think we're talking about is really thinking about how we cope with the growth of the population, but in a way that really targets resources in the right way, as Roland has illustrated, as opposed to just growing everything that we have at the minute in a proportional way, which is kind of what you can see in the middle option.
Okay. To be really kind of frank in response to that, I'm really sorry, but your answer by saying you're not talking about a reduced number of beds because obviously you're talking about going from 843 G&A beds to 1,094. With all due respect, that kind of answer is the kind of answer that from people who run major organisations really annoys people, because you don't have to be a fantastically amazing statistician to know that your report refers to a 60% expected increase in population during the next 40 years, and therefore, regardless, even somebody who maybe is not the most mathematically genius person can see that going from 843 beds to 1,094 beds, while increasing the population by 60%, is a cut in the number of beds. I know that you are entirely correct to say that absolutely it is not a cut in the number of beds, but you know that people have deep and profound concerns about their ability to access NHS care, and people know that you do the absolute best you can, you work on things. But if in presenting this report, you turn around to people and say that it isn't a cut in beds, and then in your own report you say there's a 60% increase in population, it is a cut in beds. Now, it may be entirely the right thing to do, okay? I am not a healthcare expert, I don't run hospitals. You are far more able to do this than I could possibly imagine on my very best day. But it is a cut in the number of beds. So I would perhaps encourage confidence in the fact that the decision to reduce the number of beds, relatively speaking, is the right thing to do, rather than saying it isn't. Okay, I have a couple of other things I want to touch on at this point. This may be a fairly short answer, and it may not need a great big kind of discussion, debate around it. I assume that your plans for, to use the phrase that was used earlier, care in the community, which I know isn't exactly the right phrase for what you're doing, but the idea of reducing people to go to hospital. I assume that your plans for more care to be provided at GPs and other such things is dependent upon the recruitment and staffing crisis that exists in dentistry, GP services, all the other services you're referring to, being solved by government at some point in the next 5, 10, 15, 20 years, so that those services that are needed as part of your plan to be able to reduce the number of beds at Allenbrooks, relatively speaking, are able to work, because I would assume that you can't make it work with the current recruitment and retention crisis that GPs, dentists and others face.
Claire.
I mean, can I just come back on the point of the numbers, because look, I really was not trying to obfuscate this point at all, and of course you're totally right on the statistical bit, and actually I've certainly tried, I think, in my opening remarks to be really upfront about the impact of the changing model of care, and I totally get that people are concerned about it. I'm sorry, I wasn't trying to be smart about it. I was just trying to say that we are not reducing the number more than we have at the minute. I don't want people to think it's more radical than it is. It's already quite significant. In terms of the workforce, yes, you're absolutely right. We don't have, I think, all of the wider workforce that we need at the minute to deliver these new models, and we're going to have to really think about what is the training, the pipelines, how we support people to work in a different way, and some of that is resourcing. But some of it is the kind of broader development of curricula, working with the universities and all the rest of it. Roland, I can see you've got your hand up. I'll come over to you.
Roland.
Yes, so I think the challenge around the workforce piece is that's the centerpiece for us. So I think there are definitely parts of the health and care system where people are struggling to recruit and retain staff. At CUH, we are broadly fully recruited in all of the workforce groups that we have. There are big gaps, there are gaps, but broadly speaking, we're in a strong position. But you could argue that whilst all of those are valuable key people for the model of care we've got today, as an example, we have too many specialist consultants when the direction of travel for our patients is multiple conditions, and having more generalists is what we're going to need in terms of the hospital workforce. And it's a very quick extrapolation to, and many more of those individuals working out in our communities. So I think our job is going to be to work with patients, general practice, social care to really understand what the very best model could be, and then build the workforce back from that. And we are going to need the help of the Royal Colleges in that, because it will mean quite significant changes to what they are saying they would like the members of their colleges to do. And Claire, I think there's a lot of that in the long form version of the report, but it's a key question. Thank you.
Okay, great. Thank you both for that. Just to round off from my bit here, one of the things you talked about, and it is something that we hear lots from organisations, and we talk about it within ourselves at South Cambs District Council, is the benefits that come from the use of technology for people to communicate. I will use a relevant personal example. I have elderly members of my family who cannot use the internet. Okay, I have elderly members of my family who cannot use their mobile phone to send a WhatsApp message, let alone book an appointment. They will be terrified by the idea that someone who can use a mobile phone to book an appointment will potentially find it easier to book appointments, and that they will be left behind. And I do think that sometimes for those of us who absolutely use technology on a day-to-day basis and are completely comfortable with the idea, there is a huge risk that we forget that for millions of older people, perhaps the people who create more work for the NHS than others, this is really scary. And if they don't have the benefit of having younger or more digitally savvy relatives who can literally at a moment's notice pick up responsibility for booking these appointments and contacting people, their belief would be, and I can tell you this from personal experience, their belief will be that this approach will exclude them and that other people will get the appointments first. How do you avoid that?
Claire, did you want to come in on that first? Or?
Well, it's an extremely good point, isn't it? And I think it's one we're very alive to as we're looking to introduce this technology. And it's both how we introduce it to get the benefits of new technology and working differently and more productively, but actually making sure, and I think, again, we have done this historically with the introduction of My Chart and other things, of making sure that it is not an exclusive or excluding thing. So I think it is something that we are really conscious and thoughtful of. If I use the example of the digital front door in the emergency department, which has just been introduced, that has not replaced the existing reception area. You can still go in, and actually if you can't interface with the technology and do the triage in that way, there is the same reception area with humans who can absolutely meet and respond to your needs in that way. So this isn't, I think, for us, and it's kind of all in a sort of digital technology thing. We are really trying to blend and manage the model so that it works for the full range of our patients. I don't, Roland, what would you add to that?
Roland.
Well, I mean, it's a description that could have applied to about half of our acute medical unit this morning. I'm not passing judgment on the patients and their family members who are in, but I wasn't seeing a lot of mobile phones in those 30 or 40 beds on those 2 floors. So it's very, very real. And it's something we've got to really be very thoughtful about. Absolutely no point rolling out whiz-bang technology that is scary, it doesn't work. What I hope you'll hold us to account for, and I think this is what you're pushing us to, is where we're using technology, have we gone through a process that's got really good citizen and patient engagement? And I know that you'll push us very hard on where we're using technology to support our staff to be able to provide better care. and what you want is you want our district nursing community to be able to look after more people with the right technology to get the right judgments and insights from specialists where we need them, not holding our citizens and patients at arm's length in some sort of call center on the biomedical campus. Sorry, so I'm saying it's exactly the right question. We haven't cracked it yet. Do push us really hard on how we're using technology to support staff. Thank you.
Great. Thank you both for all your answers.
Councillor Leeming.
Thank you, Chair. Thank you both for coming to speak to us this evening. I'm going to go back to the GP question again, if that's okay. A number of my colleagues have mentioned they've sort of pursued this topic. There's a few other things that I wanted to be clear about. So my first question was to do with paragraph 2.10, which it talks about the national the new sort of local healthcare hubs being a focal point for traditionally hospital-based services such as diagnostics, post-operative care and mental health services. And slightly earlier you spoke about the sort of minor injuries unit in Ely as an example of this type of arrangement, and I've taken members of my family to be treated there. I know what that place is like, and that would make sense. But the second part of the sentence goes on to speak about, as well as acting about as one-stop shops for wider health and wellbeing services such as debt management, housing advice, smoking cessation, employment support and social prescribing. Those sorts of medical and sort of community based programs are very much in GP land as far as, I mean, and I know my local GP provides many of these services. So my question was, how will these local community hubs either not duplicate the work that's going on in GP practices, or just to go back to another comment which was made, I think by Claire, which was asked about how things would be funded, and she said money will flow in a different way, and I wondered whose money, which money would be flowing in a different way. How will these things ensure that local GP practices don't end up losing funding for services that they may already provide for a service which they're undertaking at the moment? Start with that.
Claire, did you want to come in on that or first?
Oh, I'll say two things on that, and then again, Roland may want to add. So I think the first thing we're really trying to do in this paragraph is make sure that we are not describing just a medical model of health and care. So, coming at it from the hospital and in conversations with our staff, we can end up, I think, sometimes in a very kind of medical illness driven model. And we are deliberately with this trying to make sure that we are understanding social determinants. We know that people's health is affected by what else is going on more widely in their lives. We're working very closely with some of our integrated teams, and we can see that all the time. And we're trying to make sure that as we think about what the right model of urgent emergency care is for the future, that we're paying attention to that area of people's individual and community needs, as well as just the kind of very health-centred model. In terms of not duplicating, with GPs, I think this is the work of the next period of time, is to really work with our GP partners. Where specifically would we want neighbourhood health centres to be, and actually what makes sense to go there? There is absolutely no intention at all to duplicate incredibly successful services that are working well in existing places. We can absolutely then, they don't need to be in every neighbourhood health centre if actually there's an alternative provision that works elsewhere. So I think this is where we get into some quite detailed conversations around what is needed in each place. How can we really join up effectively services provided across the full range of different partners. And again, some of this space is you know, district councils are active in. How can we get that working really effectively across the partners? If we end up with duplication, we are ending up with people we're not using our resources in the most intelligent, effective way. And I think that doesn't work for anybody. So really working through what needs to be where is going to be an important part of the next phase of work.
Councillor Lehman, or Roland, did you want to come in on that as well?
Nothing to add. Thank you.
Thank you. Councillor Lehman.
Thank you. I just would like to just go back to the question about funding, really, because this is quite a radical change. How will these services be? How will they be sort of commissioned through the different sort of financial models that exist in the health service as it is today?
Thank you for that, Claire.
I'll have a go at that one. So, look, I think some of that comes back to you know, some of the work the government is doing at the minute to try and incentivise and reshape the health system. And they have, in their 10-year plan, I think, set out quite a clear model around the 3 shifts, one of which is shifting care from hospital to community. And what we can start to see is then the sort of more detailed underpinning of what does that really mean in practice, and how do different people kind of play their roles within that. So some of this, I think, can be enabled and supported by national policy. There is clearly a really important role for the ICB as the funders of healthcare. And then for us, I think it is how we work with the Cambridge South Care Partnership to really join up, as I've said before, the services that we're providing all together, so that we're making the most effective use of resources. Roland.
Yeah, thanks. Couple of points on this. So I think a complete disaster would be the hospital in sort of very lay language, hollows out the funding of out-of-hospital services by running duplicated services and all the rest of it. That would be, I mean, it would just be so undermining to the people that we're here to serve. I think there are models at the moment, or there have been over the last 10 years, where really good commissioners with good networks of providers have been able to allocate funding in a really intelligent and sensible way. More GPs and fewer gerontologists, or gerontologists in the hospital who work in the community. I think we've had a solid go at that in our system. We were quite advanced in 2014-15 with the Uniting Care Partnership. It's a huge shame that that stalled for 2 or 3 years. I think in the next phase, we're going to have to make use of all of those existing mechanisms, but in the end, we're going to have some sort of oversight through an integrated health organisation, which is the sort of model where this has worked best, where you end up with some sort of oversight board holding the contract for the population and working out where best to spend the money, which would be away from the hospital and in the community. So as a hospital chief executive reporting into that board, I would be expected to see my resources cut quite rightly to support out into the community. Thank you.
Councillor Leeming.
Thank you. I hope that you get support within from sort of national government to organise this in a way that serves the community well. I have another question, which is to do with focusing on patients, particularly patients with chronic conditions. I think it's slightly different with patients with an acute situation, which resolves quite quickly. But if patients have a sort of chronic long-term condition, how will they be able to continue to see a doctor, or at least a team of doctors who know them and have an element of continuity of care?
Claire, did you want to come in on that first?
Yes. So, I mean, I think this is, I mean, at the moment, what I would say is almost all of interactions that patients have with our specialists is via an outpatients appointment. And we have, I think, historically worked in the past where, you know, perhaps if you need to be followed up or you've got a long-term condition that, you know, will last over a period of time, you would keep coming back on a, you know, on a very regular basis. Everything was fine. You know, you were feeling well, and things, you know, there was no sort of particular healthcare need. We would call you back into hospital sort of anyway because you happened to pop up on the list. I think what we're trying to move to is a much more dynamic, responsive and accessible model of care in the future. So actually, you might not be able to wait a year for your routine appointment because something has gone wrong, the drugs aren't working for you in the same way. Actually, you want to be able to reach into the hospital and get that specialist advice and input at the point at which that starts, not waiting for your regular appointment. Equally, actually, if you're fine and things are going well in your life, you might not want to go in to hospital. You know, it might actually be quite inconvenient. You're happy to leave it longer, particularly again, if you know that if you need to, you can access that specialist, you can ask for help, and that will be responded to in a timely way. So I think for us, it's a bit about sort of rethinking what is the model that we're using? How do we make sure that the people that really need specialist input are getting it at the right time for them? And really fundamentally, I think as a patient with a long-term condition, then you're in more control of whether you're able to get a doctor's input or not. I don't know, Roland, what would you add to that?
Roland?
Well, yeah. So I go back to the COPD example. So COPD, smoker's cough, is a chronic condition. It's a long-term condition. And the model, Claire, that you're articulating is patients with COPD working with pulmonary rehabilitation, physiotherapists, nurses, community nursing teams, GPs with a special interest within a particular practice or group of practices, and then the experts, in inverted commas, who sit within the hospitals. Now, the truth is everybody across that spectrum is an expert. And where this has been done really well in the country, like Southeast London, it's been using data to identify and group patients as to whether they have really serious COPD or it's really mild, and then tailoring the package of interventions to those communities in a very specific way. So you are seeing a specialist when you really need to, but what you want is the specialist out there working with GPs at local YMCAs to design exercise and nutrition classes, group sessions. So I think it's about being very tailored and targeted. And what Southeast London have been able to do is to identify patients where the treatment was really suboptimal, wasn't great for them, and also, more importantly, be able to find patients who were suffering from COPD but didn't know, or the GP hadn't picked it up. And it's then being able to work with those communities and improve their outcomes and their quality of life. So it's a whole team approach, I think, but being very targeted.
Councillor Lehman.
Thank you. I have one completely unrelated question. You mentioned that you are doing consultation with GPs as part of the South Care Partnership. What other consultations have you done with patients, and what do you think you will be doing in the future as well in terms of patient consultation about this plan? Very grateful that you've brought it here to us to discuss, but I'm wondering about sort of regular patients. Thank you.
Claire, did you want to come in on that?
Thank you. So as part of developing this strategy, we did lots of conversations with professionals that work in the health and care system to get their experiences and ideas for how the system should work. And we also did quite a number of patient engagement events as well. I did them, Sean, our lead clinician, and a range of other people. And really that was having conversations with patients right across their experience of urgent care, acute care, the emergency department, different interactions with the hospital at different times, and interactions with other parts of the healthcare system as well, actually. So really quite wide-ranging conversations. And I think both them really reflecting on their experiences, how it felt to be a patient in our emergency department who was poorly, who was in pain, the bits that worked well, and perhaps the bits of their experience that that were more problematic, and how they would want that to be different in the future. And then we were also, I think, really trying to test with them some of these ideas around how things could be different, and kind of would that work from their perspective. So this idea, as I mentioned earlier in the call, of potentially you do have an acute health or an urgent health need, you need to be seen in hospital that day. Actually, but would it be acceptable to know that you have an appointment booked at 4 o'clock in the afternoon? You can wait at home rather than waiting in the emergency department waiting room. Kind of, is that okay from a patient's perspective? What would people be worried about? What would they need to see as a reassurance if they deteriorated, or those kinds of things? So we've had lots of those conversations with patient groups. I think what I'd say is we found it harder. We have really well developed patient engagement groups for the cancer and the children's hospitals, and we've worked with them really over a period of years to get into really quite a lot of detail about the model of care and how those new hospitals need to work for them. We found it a bit harder on the acute and emergency side, just because there's so many different types of interaction with the hospital or with healthcare system, people coming from very different perspectives. So one of the things we are really thinking about is how can we really build on and develop our patient co-design over this next phase of the acute strategy, and particularly I think thinking about really the sort of health system as a whole, so not restricting ourselves just to the bit which is, and then at this point I come into the hospital, but how would you want it to feel right across the care pathway with different interactions. So again, we're really thinking about, well, actually, if we're going to work differently with the GPs or with social care, how can we do that in a way that really works for patients?
Thank you for that. I think we'll move on, if that's okay, Councillor Lehman. Councillor Hansraj.
Hi. I just wanted to say that I'm very happy to see what you're doing, simply because I have experiences in a London hospital, but in nephrology, setting up daycare, etc., has been what I have been involved in. What happens is that these local hospitals, I forget what you call them, sorry, help people who, with transport, etc., they don't have to make the long journeys, they don't have to endure long waiting times, they have more personalized care. But this was a specialty I was working in. I don't see why it can't be working in these neighborhood community hospitals. What I am surprised at is that it has come to us now as like it is a proposal now at this point in time, when Cambridge population has been expanding for a while. I'm just wondering why it's on the table now, and it's like not even gone through solid funding proposals, etc. I mean, it's a proposal asking for funding, but there's nothing concrete. And if you take Camborne, for example, there's 30,000 people there already almost. Northstowe born, and it's now and the next thing I would like to say is that when you have these sort of community hospitals, you need the seniority. Senior nurses who can make decisions correctly. So it becomes attractive for nursing because they have additional training input, which costs money. So all that needs to be factored in. That would mean that if you say your staffing levels are wonderful at the moment, you're going to find that there is a reduction in that.
Thank you, Councillor Hansraj. I'll come over to Roland first, who's indicating to speak.
Yeah, so 2 points. I think absolutely, again, I think as we've said already, the workforce is the absolute centerpiece for all of this, and our role really amplifying and growing our use and work with apprentices is going to be key. But it's really working with Anglia Ruskin and the University of Cambridge around changing the curriculums that we have, and having a much more fluid movement in and out of the hospital across the whole healthcare system. I think the question of isn't this all a little bit late? So I'm a couple of things on that. So I'm a little bit wary on this, not wary with the question or wary with you, but we've been trying this as a system since 2014-15 with the Uniting Care Partnership. You remember that Mike Moore, the Addenbrooke's chair, and I led the STP, the Sustainability and Transformation Partnership, with Claire, ahead of it becoming an integrated care system. So we've been working on this for quite a long time whilst we've been making changes within the hospital. So I think we're really hoping that this time we're going to be able to get both the service design shifting on a gear and get the building piece working. I think on the building piece, which we're very worried about given the growth in the Cambridge population, we do have an intervening period when, as the children's and cancer hospitals come online, and building on those should start in 2027, that will give us a little bit of wiggle room alongside the use of technology to change to the workforce and some of the pathway changes we put in the acute services strategy. So it'll give us a little bit more capacity to work with over the intervening period. But we don't have forever to wait for the building of an acute services hospital. Thanks.
Councillor Hansraj.
The training is already available. You won't need to, put forward money for extra courses, etc. When it comes to reduction in beds, I understand that you're looking at different ways of working, and the use of beds themselves. However, is that really a bit too ambitious at a time when the population has increased so greatly? The struggle will not end.
Okay, thank you, Councillor Hansraj. I'll come back over to Roland.
Yes, I mean, again, we've done a lot of work on the number of beds, and I think it's a very legitimate challenge. Gosh, population, even with all these models and the growth in population, are you building a hospital that has too few beds? And I mean, Claire, we'll very happily go back and keep looking at that and keep working on it, because you're right, there are quite a lot of assumptions in there. And I don't want to give you a managerial answer about we've done the modelling and it's all okay. We're going to have to keep looking at that as we go. Claire, I mean, is there anything you'd say? We've put a lot of effort in, but go for it, yeah.
Well, I think just the only bit I'd add is, like we know that this is an ambitious model, and as I said earlier in the meeting, we deliberately tried to really think about what a genuinely different model that would be fit for 10, 20 years in the future would look like. Now, that is a as Roland says, that's really not a straightforward thing to do, and we can't just sort of maths our way through it. And I think you're totally right. As we develop this and as we start to try and implement some of these models in the next year or two, that's going to be increasingly giving us real world evidence and data about whether that ambition can really be realised. I suppose the bit I would say about the ambition is, I think if we don't start there, we potentially set ourselves down a path of building a really much bigger hospital now. And I'm not sure that is the right answer for the local population, the country as a whole. So we know there are more people coming to hospital and spending more time in hospital than is really working for their health. And I think part of what we're trying to do with that ambition is to say that we do really want to do this differently and better in the future. And so we're trying to hold ourselves, I think, to that kind of standard of, what would it take for this to be true, I suppose.
Thank you for that. Roland, did you want to speak on this point? Yeah.
Yes, yeah, sort of another angle, and I think this is also what you're challenging us on is, and we're not being reckless or cynical, but we know that the current model is not affordable, and we know it's quite often really inappropriate for the communities, our population and our patients. So what we're doing here is we're looking around the world and we're saying, what are the very best possible models and how do we think we could take those further? And then let's build to that. And that will in itself enable the change. Now, if we build another 150 acute medical beds and we recruit the doctors and nurses for those, the likelihood of the model continuing as it is, which is not appropriate, is quite high. So we're trying to really enable in quite a purposeful way the change that we're talking about. The other piece here is our experience has been that to get these things actually built and invested, they've got to be acceptable to the taxpayer. And you can imagine a world where you're talking about a 3, 4, 5 billion pound hospital build. The likelihood of that getting funded is very, very low. Whereas if we can turn this into something that is sort of co-funded and is a sum of money that we can get our heads around, it's much more likely to actually get built. And that's going to be better than the non-built bigger thing that we don't think we want anyway. Thank you. I'll hand back.
Okay, thank you for that. Should we, Councillor Hansworth, can we, do you want another point? Yeah, please do, yeah.
Please, could you explain what you mean by co-funding?
Roland.
Yeah. Yes, so the children's and cancer hospitals are in effect co-funded by the government, philanthropy, the University of Cambridge, and industry in some cases. So to give you an example, in the cancer hospital, AstraZeneca are taking space for 70 scientists, which is going to be good for patients, good for the university, good for AstraZeneca, good for the NHS. That's what I mean by a co-funded model. Now, cancer, children's, neurosciences, diabetes, obesity, respiratory lend themselves very well to those sorts of co-funded models in terms of the capital investment to build the building. Claire, I think there's still quite a long way for us to go on the co-funding model for what's a major service redesign with what's a kind of core NHS facility at its heart. But there's definitely areas there that are going to be important because in the end, our industry and university partners know that the future is going to be getting into these, how we have much better holistic treatment for people with multiple conditions. Thanks.
Thanks. Claire, did you want to add? No. Okay.
I don't think so. Thank you.
Thank you. Okay, we'll move on. Lovely. Thank you, Councillor Hansworth. So we've got Councillor Lena Nieto.
Good evening, Claire and Roland. Thank you so much for coming, for being here today and at this hour. I mean, I experienced, everything that you're saying, I think makes sense. I experienced, going to A&E just because my son had a nosebleed and there was no other care. And I know that this is not acute, but it does show that potentially, and yeah, quite likely, the service is not fit for purpose as it is, because a lot of the pressure could be taken off from the services being provided in the city. I think my concerns are mainly around the impact on rural communities, because everything tends to be very city or urban centric. So it's how you're going to be thinking about residents that live in the rural communities and how they will be provided for these services. So it's really important because there are quite a lot of differences between urban and rural, as we stand in South Cambridge, which is quite rural. I'm interested to understand what KPIs and milestones you currently have to track progress on this new model and its success. I don't know if you have reached that point once it is operational. The other question I had was what contingency plans exist if partner organizations lack the capacity to deliver the services that you're looking to provide. And then I'll continue with the others.
Yeah, lovely. Claire, did you want to come in first, or?
I was hoping Roland might, but yeah, okay. So shall I? I'll have a go at those, and I'm sure again Roland will you will add to my answers because they're all terrific questions. So look, I'll in reverse order. So contingency plans. So this is not, I think, a kind of a strategy and a model that we are charging ahead with and we'll implement come what may. This is us trying to be really thoughtful about what the urgent and emergency care system of the future needs to look like, and then start to have the right conversations with our partners, work collaboratively with them and build the capacity together. And I think we are not, so far down any particular path at the minute that we can't change that and adapt and develop it as we grow. And I'm absolutely certain as we continue to go through this process, we will find some things working better than we've anticipated, other things perhaps not working in quite the same way. And we'll need to be quite thoughtful and responsive to that so that we develop plans that actually can work in due course. I mean, KPIs and milestones, I mean, I think we're in this two different bits. And again, I talked about the sort of next steps for this work in my opening presentation. The first area is on doing the next piece of work on the design of the acute hospital. And in effect, that is on pause at the minute and until hopefully we get some further funding via the Cambridge Growth Company, probably to enable us to start that work. And that's things like appointing architects and health planners and really getting into the detail of the design of the building. The other area that we're paying a lot of attention to at the minute is starting to trial those new models, different ways of working, developing kind of pilot services and areas where we can start to test some of these ideas in practice. And so actually there's things like the implementation of the first phase of the digital front door that went live last Monday, the 1st of December. There will be other things that we're looking to implement over the course of the next year or so to help us start to, I suppose, sort of build that path from where we are now to the future. And then on travel, I'm afraid I don't have a really neat, good answer for this because I think it is sort of a feature of our geography, and it is a real challenge, isn't it, for local communities now. And I'm talking to you from Barrington, lovely village in South Cambridgeshire, so I have very direct personal experience of this. I think it's just something we're going to have to work through as we look at which services are best placed in which places. I think some of the virtual and digital technology can potentially help with some of that, though obviously that has to be done in a really thoughtful way, and I'm very mindful of Councillor Drew's comments on this, but it can help for some areas. But equally, I suppose there isn't a sort of neat answer to it, but we're going to have to get into what makes sense in which places. And sorry, I'm a bit all over the place. The final point on this, I was just going to say, is I think this is one of the things that makes doing this in Cambridgeshire very different actually from doing it in London, where some of those things around having the right footfall and people being able to get there are less of a challenge. So I think for us, being really thoughtful about access, whether it works for enough people, can actually we get the efficiency? If we're going to have lots of highly trained members of staff somewhere, it doesn't work if we're not seeing enough people. So we're going to have to do, I think, a lot more work on how that really works in practice.
Thank you for that. Roland, did you want to add anything?
Nothing to add.
Thank you.
No.
Okay, so Councillor Nieto.
Thank you, Chair. I mean, KPIs and kind of its program data, or establishing some kind of evaluation metrics, because we would want to make sure that the new model works, right? So I'm assuming that there will be a thorough evaluation that this new model is going to be working. So I understand that the KPIs are maybe not in place at the moment, but I would expect later on, as things progress, that there will be clear metrics.
I'm seeing lots of nodding, so I'm assuming that will be the case.
That's going to be taking place from an evaluation perspective. The other question that I had was, is there anything that the council can do to support the successful implementation of this new model? Is there anything that we can do locally to support you? And also, will you consider kind of providing the council with updates on implementation, risks, and impacts on the local community as the program evolves and the strategies is further formed? Thank you.
Thank you for that. And I know we already have some engagement, I think, through Simon Day and the briefings that we have. But if you could come back to Councillor Nieto on how we'll be kept up to date with this process going forward, and what we can do as a council. Roland, you're indicating to speak?
Yes, so I think so, absolutely on KPIs, and there's a lot of things that we track at the moment. As you can imagine, things like the extent to which we have to readmit patients or the length of stay for patients. I think, Claire, what's at the heart of this, though, is a new approach to, in inverted commas, KPIs, where I think patient feedback will be hugely important. The extent to which we're seeing off deteriorations in people's conditions before they ever end up touching the hospital or general practice is going to be important. Where we could do with your help, you've always been fantastic partners to us. You've challenged us, held us to account, but you've also helped us when we've asked for help. As an example, in the past, you've helped us with patients who are at the end of their stay in their hospital and helping us enable those patients to go back to home or to wherever they live. And I think that sort of intervention, I think, is something we'll want to work with you on across the whole health and care system. I think in the short term, over the next 6 months, your vocal support for the releasing of some of that money from the Cambridge Growth Company to let us move forward with the next phase of the business case would be gratefully received. That would just help us to keep the momentum that we've built over the last year going. And absolutely, I very much hope we'll be able to come back for regular updates as we go and to be held to account to make sure we're delivering. The only other thing I'd just add is, I think very important we're tracking KPIs, but the point you made around evaluation is what also matters, because we need to be able to demonstrate that the patient outcomes are better from this model so that it can be a good example for the rest of the country to follow in the same way that we look at inner South East London on COPD. Thank you.
Thank you. Councillor Nieto, did you have anything else?
Thank you so much. Just one last one, Chair. I just wanted to explore if there are any, and maybe you haven't yet worked this through, but are there any at the moment, any policies or regulatory legislative barriers that would prevent you from implementing this or going any further that you think government should be considering or reconsidering that could help drive innovation and for the healthcare system to be more innovative, more agile, more adaptive to current needs, and to change kind of the status quo if it's not fit for purpose?
Thank you. Roland. You're on mute, Roland.
So I think the 10-year plan is a very strong manifesto. It's a very strong vision. And I think the early stages of implementation around a focus on money and waiting times has been the right thing to do. And it's up to Claire and I to make sure we don't drop the ball on quality. We maintain a strong focus on that and on staff experience. We don't overdo that. I'm very pleased to see the government starting to push on the use of technology to improve waiting times and quality, and new models of care, new ways of working. We had a visit from Lord Carter today to our histopathology laboratory, which uses automation and is enormously supported by staff. And this is where we're really able to speed up diagnosis of cancer. But where I think we need to go further is a much more radical approach to how we work with patients in areas like dermatology, to change pathways of care. And I think that's an area I know that the government are thinking about, NHS England are thinking about, but it's going to have to come really quite quickly so we don't run out of road. Thank you.
Thank you. I think we'll move on. So Councillor Rippeth, please, Judith Rippeth.
Thank you. Yeah, before I ask my questions, I'd like to say that I find the Ely Princess of Wales Hospital was provided a really good service recently to my family, and it seemed to operate a little bit like that neighbourhood hub. It was quick and it kind of worked. You weren't hanging around for ages. So to move on to neighbourhood hubs that you're envisaging, just a really simple question. What kind of hours do you imagine they will, operate?
Thank you. Claire, did you want to come in on that?
Well, look, I think the very short and straightforward answer there is we just have not got into that level of detail yet. So clearly, if these are going to be useful services and a proper alternative to an accident and emergency department, I'm sorry if you can hear my daughter in the background, then they will need to be open for extended hours. I can't make a detailed commitment around exactly what that model of care would look like at the minute. We just haven't got into that level of detail.
Thank you. Councillor Rippeth.
Yeah, I know you won't know the exact hours, but I suppose I'm just hoping that it's going to be flexible because modern lifestyles have changed and this is a modernisation of the system. And my second question, which maybe is a bit beyond your remit, so I'm not sure, is how do you plan to sort of educate us as a population on this? Because as other councillors have mentioned, there will be fear around it, especially with certain demographics and age groups. But we need to be able to change our mindset as well for it to work. Or are you kind of hoping that's gradually changing, and by the time, say, the acute hospital is up and running and you've got the neighbourhood hubs, that we would have kind of made our way towards that? Or is there an education programme that you're going to engage with the communities with?
Thank you for that, Councillor Rippeth.
Yeah.
Roland? Yeah.
Yes, so again, a lot of the things set out in the 10-year plan are going to take quite a sustained change in the way that we interact with health and care services, and that will take time. I think what we're signalling here is two things. The first is the need to engage our communities from the outset, which is very much what Claire and the team have done with the acute services strategy in its design, and that's building on the experience we've had with children's and cancer. And then you mentioned the word neighbourhoods. In the end, this is going to be about how local communities are engaged with at a very local level. And the work we've already done, I think, over the last 3 years, led by Heather, at a neighbourhood level has been, I think, what's enabled some of the changes we've seen already. So engage people from the outset, think about local communication. And crudely, yes, we'll do the videos and the pamphlets and the clear and simple documents, but it's the first two things that will make the difference. Thanks.
Thank you for that. Lovely. Okay, I'm going to bring some people in that have already spoken but had indicated to speak again. Councillor Earl, did you want to come back in?
Yes, I do actually. Just going back to Councillor Drew's observation about the way we've reduced the number of beds per capita in this country. I don't know whether other people are aware, but since the last 50 years, we've reduced the number of hospital beds from roughly 10 per 1,000 down to 2.3, which is much lower than most of Western Europe. Germany has about 7 beds per 100,000. France has 5. Scandinavian countries have far less. Are the Scandinavian countries, with their greater reliance on community services, a model that has been looked at in relation to this document, your plan? And if that's the case, how much per capita is being spent on healthcare by government in Denmark and Sweden, where these figures come from, in terms of GDP, in comparison with what we spend, and how much you're going to get from central government to put these plans into effect?
Thank you for that, Councillor Earl. Roland, I don't expect you to have the figures off the top of your head, but if you could attempt to make that comparison, that would be helpful.
Yes, that's a good punchy leap into global health policy and strategy. So thank you for that on a wet December evening. Joking aside, so first thing is absolutely we've looked at other models in this country, but also at other models internationally to see how are the very best places moving things forward, but always thinking about and how are they doing that within a constrained financial envelope, which means that you would look at the United States, broadly speaking, 18 or 19% of GDP. You would see are those models applicable here in a context where, I'm going to get this slightly wrong, Claire, but we've now moved from, I'm going to say, around about 9, 10 to more like 11, 12. So we have looked across the world, and some of the Scandinavian models are very exciting and interesting. But again, they've always got different context, which you've also got to look at. I think in terms of where we are as a percentage of GDP, I think the latest analysis that Lord Darcy set out said that we had moved ourselves into being much more comparable than we were a few years ago. And I think quite a lot of us are far from convinced that we should be trying to spend more percentage of GDP on the NHS and on healthcare. If you think about the power of education, social care, much better community infrastructure. So I suppose what I'm signaling there is quite an anxiety about going up to the sort of top end of our peer group.
Thank you.
That'd be quite dangerous.
Thank you. Claire, did you want to come in on that?
Just because I think this circles back to Roland's point earlier about where the resource is spent, and we did talk to some colleagues from Scandinavia as part of the case study development, and one of them said something very clear to me. They said, look, the things that really cost money in the healthcare system are buildings and the people. And so what we are trying to do with our design of our system is to be really thoughtful about how we use the buildings and the staff in the most efficient and effective way possible. So actually you're coming into a healthcare facility when you really need that interaction. And when you're in front of a highly trained professional, that is absolutely the interaction that you need at that time. And I think that's a really good and interesting model for us to think about, where actually are people getting the value from their interaction with the healthcare system, and how do we make the best use of our resources.
Thank you for that. Councillor Earl, did you want to come back at all? Are you happy with that response?
I did slightly, in that we do run on a very, very low number of beds per capita, in particular intensive care beds. And we learnt during COVID that the NHS has very, very, very little slack in the system. Addenbrooke's in particular, I've personally experienced being bounced from an appointment on one occasion because of that. I'm just wondering how this model with fewer beds per capita, and I'm not sure that the community hubs are going to have beds for low dependency, perhaps people who need to come in for some post-operative care when they've been discharged from the acute hospital, elderly perhaps, or disabled, who need to be looked after in person, not at home via a digital system. How is it going to cope with that? And has that been costed in? You know, reducing acute care leaves very little slack when there's a problem. And also, if you've got people who need to be cared for physically, who don't need to be in an acute setting, how will that be coped with? Are you envisaging that the community hubs actually do have some beds for overnight stays, for example?
Thank you for that, Councillor Earl. Roland.
Yes, I come back here to what we're finding is best for patients. So I think if I was to give you two examples of areas of change, and I've alluded to these already. So over the last 5 or 6 years, or more, slightly longer, it started before COVID. If you imagine where the Addenbrooke's A&E is, there are 3-4 floors above that, the EAU block. And what we've been doing there is repurposing what were bedded areas into short stay bedded areas, but also seats and trolleys. And the whole model is one of really intensive diagnostics, and then making a rapid diagnosis of what the patient is facing, and then coming up with a definitive plan. And if we do need to admit the patient to the hospital, we do so, but we're doing all we can to find out what's wrong, treat the patient in the chair if at all possible, and then get them back home where they're safest and can carry on with their daily lives. So that's an example where we have reduced the number of beds, improved patient outcomes and patient experience. And yes, we do sometimes get that wrong. We sometimes discharge patients too early, but generally speaking, both the feedback that we've had and the outcomes that we've tracked have been better. The other example I alluded to already was the Cambridge Movement Surgical Hub, which in the original business case started as 40 beds and 3 theatres. And this is where we're doing the hips and knees joint replacements in a dedicated facilities, and we're doing quite a lot of spinal work. And the example I gave there was, in the model that we had, length of stay was just under 5 days for each of the patients for a joint replacement. We went and looked at the northeast of the country where they're doing this well, and the number came down to about 2.5 days per patient. But what's happened is, as we've got the physiotherapists really leading both the preparation of patients for their joint replacement and intervening as soon as the patient comes out of theatre, that length of stay is basically a day. We call it a 23-hour facility for quite a lot of those patients, so between 1 and 2 days. So those are the sorts of models where we think we're delivering much better outcomes for patients, and we've got the model of staff and working with patients better. And that's very much, I think we're then going back into the answers we've given already about why we've gone for this number of beds. Thank you.
Yeah, okay. Councillor Earl, did you want to comment?
That's encouraging to listen to, but it didn't really address my question, which was that isn't always appropriate for elderly and frail people who perhaps need a step down, and I'm wondering if that actually is in the plans to have step down beds for people who may not be suitable for discharging after 24 hours.
Thank you. Roland, did you want to comment on that any further?
Yes, so in the modelling, there is already quite a lot across the health and care system. There is quite a lot of, in inverted commas, not being pejorative, but additional facilities and capacity that we can use when patients need a little bit longer in a hospital bed. But again, it's often the best thing for the patient is to be doing all you can to get them back home. And the sort of language that's used very openly, which is use it or lose it, which is once people end up in a bed for a long period of time, they start to decondition. You know all of this. Their muscle mass goes, their skin becomes weaker. So it's very important to always thinking, what's the very best thing for this patient if I'm going to enable them to live the very best, have the very best quality of life. But I'm not saying it's not important. In many cases, it really is. And we have wards in the hospital where we are hanging on to people just that little bit longer to make sure that they're doing well. Thank you.
Thank you for that. I think we'll move on if that's okay. So I've got 2 additional speakers, and if I could ask you just to keep your comments fairly concise and try not to have too much repetition. So I'll come to Councillor James Hobro and then Councillor Anna Bradnam. Councillor Hobro.
Thank you. So I just wanted to move on to the topic of patient data, because you've listed that as the first item under enablers. So it seems, from reading between the lines, it seems that improvements in data management and data analysis are likely to be important in delivering the kinds of changes that you've got in mind. I'm guessing this applies to streamlining care, but also the process of moving towards being more proactive and less reactive in treatment. So I wondered, what do you see as being the main challenges around data management? So are they about data management internal to Cambridge University hospitals or wider issues in the NHS? Or are they to do with exchanging data with organisations such as this council or sharing? Or are there more fundamental issues around consent, either legal ones or in terms of acceptance, that would affect the strategy here? So what kind of changes would be required in the area of data management and data analysis to enable the developments that you've got in mind?
Thank you for that, Councillor Hobro. Roland.
So 3 points I'd make here. I think at its heart, what we've got to continue to do is to maintain the confidence of our communities in how their data is being used to improve care. And that is in solid shape at the moment, but we're going to need to maintain that. And you'll be aware of things like the federated data platform and the role of Palantir in that is quite contentious in terms of how people believe that their data is being used. So I think, number one, we have to maintain confidence in how our data is being used to improve care and how it is being used appropriately for research and to enable improvements in care. Then very specifically, there are 2 areas where we've got work to do. One of them is improving access to data from our electronic patient record within the hospital. We are 10 years in with EPIC, our electronic patient record. We're doing a lot of work at the moment, Claire, aren't we, on how we extract that data so we can use it better. And then, to use an acronym, is how we continue to lead the secure data environment, which is really the mechanism we're now trying to use to join up the data systems from across the patch. So I'd say that those are the 2 areas we need to be able to work on. Claire.
Just a third area that I would add in, because I think there is increasingly some quite interesting and exciting research coming out in the kind of sphere of people's own personal data and how we help. So this isn't sharing it with anybody or going into any research, but we now know, I think, don't we, Roland, from some research, that actually it is possible to track a deterioration in a long-term condition, for example, ahead of that person actually becoming sick. So when we're talking about this kind of predictive, preventative use of data, we're talking about a person as an individual being able to derive insights from their own, kind of physiology, using a wearable or whatever, and actually be able to take action before they have an asthma attack or, you know, whatever exacerbation it is, and avoiding that admission or attendance to hospital. So that's a very different kind of thing that I say is very geared towards the person and their health. But that is something that I think we think could help reduce people's overall need for healthcare in the future.
Thank you for that. Councillor Hobro.
Yeah, that's good. I mean, I can see lots of potential challenges here, but it's really good to hear the issues that you're focusing on at this point. So a couple of other really quick things. There are just a couple of things I kind of thought I might see in the report but didn't, and I wondered what your views are on those. So the first was, do you have any aim for an increased role for pharmacists in these plans? Because I know that pharmacists do, in some other countries, pharmacists play a slightly more significant role in healthcare than they do typically in the UK. And the second one was things like mobile warden schemes that this council is quite heavily involved with. They have the aim of reducing the pressure on acute care services. So I wondered if there's any sort of coordination with that kind of scheme. That would seem to relate to section 3.6.1 about the strategy for people living with frailty. So I wondered if you had any comments on those. Thanks.
Thank you for that. Claire or Roland, are you indicating to speak? Yeah, Roland.
Yes. So I'd say yes to both of those as being partners in thinking about how our communities and neighbourhoods work. And as you'll know, there'll be many other different organisations or partners we'll need to have involved.
Thank you.
And can I just, if I just add, I think the Cambridge and South Care partnership is the mechanism for doing that. So pharmacy as primary care, round the table. The chair of the care partnership is your chief exec at South Cams, Liz Watts. So we are really trying to make sure that we've got the right partners around the table with that care partnership so that we can have those conversations.
Councillor Hobro.
Great, thank you very much. I'll pass on to someone else.
Lovely. Councillor Bradnam.
Thank you. Right, so two linked questions, if I may, which I'll give you both together so you can answer them as one if you want. So I'm just sort of thinking how this neighbourhood hub model is going to work with the GP surgery business model. You know, these are partnerships that doctors currently invest in. And, you know, when they retire, they take money out of that system in order to achieve their pension. So how is that going to work with this scheme? And in addition to that, are you planning to build any new ones? And I mentioned this earlier on. Do you have any plans to sort of seek S106 funding from new developments in order to provide new premises? Because currently people often say when they're looking at planning applications, oh, but we need more capacity at our doctor's surgery, and then the health providers, the integrated care board said, oh, we have no need, we can't justify that. So that's a bit frustrating. So that's sort of the money and the business model, and will there be new ones? And secondly, actually, it might be easy to answer that one first.
Happy to do that. Roland is indicating to speak.
Yes, so you'll know that there's a national debate going on the future of the GP contract and the GP model. I think that sits alongside new models of workforce development, the role of specialist services, and I could go on, but there is an active debate there about whether the GP model has had its time. I think we are keen to avoid getting distracted by that and to think about the patient, think about the neighbourhoods, the localities, and think about how we can support GPs in their model, where the model is working, and where it isn't working, what are the alternatives we might be able to put in place. So that's what I'd say on that. And then I think on the Section 106 money, you'll know again, I think the Cambridge Growth Company is looking at how are we going to fund the development of Cambridge and South Cambridgeshire in an appropriate way. And clearly Section 106 development money is going to be one element of that. And what we're really seeing, I think, is what I would call pump priming money from government that will then enable the developments that we need, but there'll need to be the sort of tariff on those through Section 106 and other things to be able to fund the investment that we need. As you would see at King's Cross, and I could go on and on and on.
Thank you for that. Councillor Bradnam.
Thank you very much. I think that is going to need a good deal of consideration. And the second element is if you've got a number of services that used to be delivered at a hospital in remoter locations, and I don't mean remote locations, I mean remote from the hospital, there's a certain heft of expertise in a hospital premises. So quick diversion, I used to work in research ethics with the National Patient Safety Agency, and when we were looking at trials for research studies, one of the questions that we always asked, or the committee members always asked, was where's the nearest hospital if something goes wrong, so that they knew that there was a support mechanism, so if something went wrong in the trial, the person could be retrieved to an emergency situation. Obviously that doesn't happen very often, thankfully, but it does sometimes. And I'm just wondering, more in the sense of the backup for the specialists that are working in these hubs, how will they be supported professionally and in terms of specialist, support, advice, backup, someone on the end of the phone if something goes slightly wrong? How will they be supported in these hubs or specialist centres?
Thank you, Councillor Bradnam. Roland.
Yes, it's again really important. We work that out in detail as we move from the model we've got at the moment to what we're articulating here. What I'd say is this is one area where we already have a huge amount of support and back and forth. So if I was to take you down to level 1 at Addenbrooke's to the contact centre, which is a lot more than a call centre, you'll see, or you'll be able to listen into the calls and hear GPs or other clinicians calling in asking for advice and guidance from across the region. And that's something we do a lot of. So if you look at how we now run our paediatric intensive care unit across the whole of the east of England, it's a sort of 24/7 on-call system that lets us provide advice, support, often using remote videoing and monitoring of vital signs of some of our smallest patients across the east. So it's going to be a lot of that sort of support, which I think we've got reasonably well established. I think the next phase of this across the region is joint appointments at senior doctor level. And getting the, and this again comes back to not having more doctors and nurses doing more of the same. It's a different model of care. Thanks.
Thank you. Councillor Bradnam.
Thank you. I think it's also, I assume, if something drastic went wrong, patients would be taken to a major hospital for support.
Yes.
Yeah. Okay.
Yeah.
Thank you.
Thank you for that. Do we have any other speakers? I've not got any listed. In that case, I'm just going to make a couple of points as chair. I don't expect an answer to either of these really. I was just going to talk about with any new acute service sort of integrating the hospital note system. We've got the 2 new hospitals coming online, the paediatric hospital and the cancer hospital. But recently we've had Papworth Hospital on site, which is using a different medical note system to Addenbrooke's. And it would be nice to think that would be integrated as time, and that would be considered as time goes forward. The other thing I was just going to say is I agree with you in that I think it's very good to have some private sector and other entities involved with the delivery of NHS services and the delivery of new buildings and hospitals on site. The other thing that I would like to be forefront is the sort of third sector, if you like, so charitable organisations, of which there are many on site at Addenbrooke's, but also adjacent to the hospital that work alongside. So I think, you know, that being considered in the development of the acute hospital. So I think we'll leave it there, other than just to say thank you very much for taking over 2 hours worth of questions from the committee. And we are very grateful as a committee for you bringing the report forward for us to scrutinise. And you know, if you could keep us informed of progress on that in the future, I think the committee would be very grateful for that. So thank you for your attendance.
Thank you for having us.
Well, thank you for having us.
Really helpful.
Thank you.
Thank
Have a
you.
good rest of your evening. Bye.
Thank you.
Bye.
Thank you very much to both of you. Thank you.
Thank you.
Thanks.
So we will move on to the next agenda item. I think we've covered the points of discussion as a result of the report. Is the committee happy that we've done that? So at the end of the report, the three discussion points is kind of what we've been asked to look at. So on page 22, we've discussed those points essentially and raised questions to the author of the report and the Chief Executive. So we will now move on to the next agenda item, which is agenda item 7, the work programme, pages 25 to 43. You've got the documents in front of you. If anybody has any questions on those or things that they would like to add to the work programme or ideas for up and coming meetings, please approach Councillor Drew or myself, and we will do our best to reflect what the committee wants to scrutinise as we move forward into 26. So does anybody have any questions on that? Okay, if any do come up, just speak to Councillor Drew or myself. Then we'll move on to agenda item 8, which is to note the date of the next meeting. That is the 15th of January. Just to make the committee aware, it's possible we may have a further meeting in January towards the end, and I'm sorry that will be another scrutiny committee meeting, but in the last week of January, likely the 29th, I believe, we will look to scrutinise the development partnership. With Peter Freeman coming for that one. So, which is something that the committee had asked to be scrutinised. So I'm sorry that will lead to a further meeting, but I think it is something that you were keen to see. So that brings us to a close. Thank you all for your attendance.